Patel, who has done great things while she's here, is now going to speak to us on some of the work that she's been doing related to COVID and candidal and non-viral co-infections. So, Purvi, take it away.
All right, thank you. Thanks, Dr. K. I'm going to share my screen. Okay. Do you guys see my screen now?
Yeah.
Okay, so what I am going to talk, I'm going to talk about a project that Dr. Womack and a bunch of us are working on. It's about outcomes and associated risk factors for like Candidemia co-infection in severely COVID-19 patients. Last 2 years, everyone has been affected by COVID. COVID was first declared pandemic by WHO in March 2020, and surpassed about 295 million cases and about 5.46 million deaths, according to the Johns Hopkins tracker. Also, just a little bit about COVID-19. It's a coronavirus. It's an enveloped single-stranded virus, and it invades our immunity body through human angiotensin converting enzyme 2 ACE2 receptors, and which is located on many organs and tissue in our body, such as like lung, heart, kidney, bladder. It affects almost every organ. COVID causes different spectrum, present with like different spectrum of severity. It ranges from like asymptomatic to critical disease. So majority of the cases that we have, about 81%, they are asymptomatic or self-limiting or with a mild disease. And basically those are like with fever, cough, headache, like flu-like symptoms. There are about 14 to 15% of patients' cases that are basically severe disease. They present like dyspnea, hypoxia. They have more than 50% of the lung involvement and the imaging within 24 to 48 hours, and require supplemental oxygen. And those are the ones gets admitted, as well as moderate to severe people. And critically ill, like the critical spectrum, basically they involve failure, shock, and multi-organ dysfunction, and those are like about 5% of these cases. We've all seen this multiple times before. I am not going to talk about the therapies, and also this is not the right therapy at the moment. Some of them are old. Basically, this why I wanted to bring it up is because just to show you that like they're like a viral phase as well as the inflammatory phase, right? So the early on is the early infection viral phase, and you present with like a mild symptoms with fever, cough, and can have lymphopenia. But as you progress through the disease, you could have the inflammatory phase, and that causes like an ARDS, shock, multi-organ failure, and that is attributed to the elevated inflammatory factors. And that's the pro-inflammatory phase that we called, and it's basically you get increased IL-1, IL-6, and tumor necrosis factor, and had fewer CD4, CD8 cells, and basically increases the susceptibility for like a secondary blood infection or bacterial or like a fungal infection secondary to that. And we have seen like a secondary infections even with like the prior influenza or any other viral respiratory illness. So this is something, it has happened with the pro-inflammatory, but like with COVID, it's special. And today I'm mainly focusing on the invasive fungal infection. So they're associated with increasingly recognized or like seen with severely respiratory viral illness. Beginning of the COVID, we've seen pulmonary aspergillosis associated and with the COVID, as well as lately we've heard a lot about mucormycosis, candidiasis, and like other endemic mycosis. With fungal infection, it can be tricky and difficult to diagnose, and it's often associated with poor outcomes. So kappa, that's the COVID-associated pulmonary aspergillosis, is in the critically ill populations, and it has a high incidence, about 20 to 30%. And COVID-19 associated mucormycosis, which we lately heard last year a lot about it from India, and the cases were like rising to the roof, and more than about 20,000 cases has been reported so far. It's associated with like high mortality, can have like like other complications like cavernous sinus thrombosis, disseminated infection, osteomyelitis, and death. And now about invasive candidiasis, where there are more and more research coming out. So invasive candidiasis, it has been reported. There are multiple studies that show that like there is an increase of like about 3 to 8-fold of candidemia associated with COVID compared to non-COVID 19, like pre-no COVID era, right, with any viral illnesses. So there is no like a reason for like higher disease frequency are still unclear, and differences in underlying disease or disease severity at ICU or classic risk factors for invasive candidiasis between patients with and without COVID have not been identified. We know like the classic risk factors, right, for the candidemia, candida disease, like if there's like a prolonged ICU stay, if they're on in mechanical ventilator for a long time, ECMO, if they're on broad spectrum antibiotics, also like renal replacement therapy, dialysis, and also the if there's any central lines available. So with this in mind, small background in the mind, I just want to bring this study up. It was done by Dr. Bob, published in IDSA last year, just to highlight our institute work. This study shows that risk factors and outcomes of hospitalized patient with COVID and the secondary bloodstream infection. So basically, it's a multi-center case control study of bacterial and fungal bloodstream infection, secondary bloodstream infection, hospitalized patient who were diagnosed with severe COVID-19, and they collected data from March 1, 2020 to May 7, 2020. And the cases were defined as patient with like confirmed bloodstream infection, and they had controls and the cases. And then the controls were basically the patients without any bloodstream infection. And then the control cases, well, mistake was made here, it's control here. Basically, it is the one only with the COVID and the bloodstream infection. So data were collected from 3 different hospitals: Robert Wood Johnson University Hospital and Robert Wood Johnson University at Somerset. They collected about 375 hospitalized patients. Included 375 patients, and out of them, 128 had secondary bloodstream infections and during the hospitalization. And they discovered that like first set of positive blood clots was about 117, which is basically 91%, and bacterial, and 7, which is 5.5%, were fungal. Their main thing was identifying the bacterial disease, and they found 7 of them were fungal disease. And they also found that like the mortality was a lot higher with the bloodstream infection versus the controls, which were only the COVID, which were not COVID. And it was about 53 versus 32. I do want to highlight this figure from that same study, that they found the gram-negative rods as the top leader in the bloodstream infection, followed by coag-negative Staph aureus, and then Enterococcus strep and the other ones. And you can see the yeast is only there, found about 7 patients were positive. Number of positive cultures were found. The second article that I wanted to highlight was just to give you our study background is because it's like a characteristic of like candidemia in COVID-19 patients. And it was a retrospective study. It was published in May of 2021, and it was conducted in the ICU of Ankara about hospital for 2 years. And they divided the study either with pre-pandemic and pandemic periods. And they looked at the epidemiologic clinical characteristic of candidemia patients and risk factors for mortality in candidemia. They had altogether of 236 candidemia episodes, 105 were COVID-19 and 131 were non-COVID-19 patients. And what they found it was that there were higher incidence of COVID candidemia in COVID group versus the non-COVID. And they also discovered that like a candidemia was developed 2 weeks earlier in the COVID-19 groups and resulted in higher mortality. And they also noted that like the high risk factors for mortality in candidemia was highly associated with like a steroid use, presence of like sepsis, and if they're older than 65 years. They were like independent risk factor they found. And this is just the baseline demographic. I just want to point it out because this is pretty much similar to what we have as well. So this is basically the all patients column characteristic, COVID-19 with the candidemia and non-COVID-19 patients with candidemia here. So it's the disease of the medical history was like pretty wide range, and just wanted to point it out like a CAD were higher in the COVID-19 with the candidemia. Heart failure were more in the non-COVID, and pulmonary disease, if they have a chronic pulmonary disease, was also with the COVID-19. And when it comes to central venous catheter, they actually had a similar percentage, 94, 98 throughout the both group. And there were more apparently used into the non-COVID patients. And this was the multivariant logistic regression they did it for risk factors for the mortality. And the variables were like age over 65, admissions diagnosis for the COVID, antifungal treatment over over than 3 days, higher steroid use, presence of sepsis, and candida species. And mainly, you can see that like a high candidemia mortality were with like the age, as well as like a sepsis. So with this in mind, our study objective was basically look at the epidemiologic, like risk factors, if there's infection site, or the Candida fungemia, co-infection and also the mortality in patient with COVID-19. So ours were all COVID-19, not non-COVID or anything, neither pre-COVID era either. So this was a multi-center retrospective case control study during the April 2020 to April 2021. And we included all the patients who were at least 18 years of age and confirmed diagnosis of COVID. And we excluded patients that were prisoners or pregnant women, children, patients who died within 24 hours of admissions. We had a similar study design as the one Dr. Butt study. Was like cases and control. So cases were basically patients with COVID-19 and who developed fungemia. And then controls were basically only COVID-19 patient who did not have any fungemia. And we selected each patient's, each cohorts manually in a 2-to-1 fashion. So every one case will had a 2 controls. And when we manually selected the patients, we make sure that they were matching, their admission date were similar, maybe 1 or 2 days or 1 or 3 days apart. They were all admitted to they were admitted at least to, or at least even they weren't admitted in the starting admission was in the ICU, but they were admitted to ICU at the end of the day. And then the severity was also similar to like decrease the paths. We used RADCAP, the Research Electronic Data Capture, to collect our data. Baseline character, we collected baseline characteristics in terms of like age, sex, BMI, height, severity of illness, SOFA score at the ICU admission, Charleston Comorbidity Index, past medical history, duration of the COVID symptoms prior to admissions, and then if there was any chronic steroid use. In terms of clinical information, we collected length of hospital stay and also the ICU stay. Also types of respiratory support they were requiring during the stay, either nasal cannula, just the high flow BiPAP, ventilated or whatnot, as well as if they had any central line placement, if they were ever get a tracheostomy. We did some biomarkers as well, like CRP, ferritin, LDH, D-dimer, and white blood cell lymphocytes, and they were both assessed at like admissions and at the diagnosis of fungemia. So about 48 to 72 hours, within 48 to 72 hours. In terms of the number of, and also like in terms of the fungemia diagnosis, we collected number of days from the admission when the fungemia was discovered, and also the blood cultures, also the T2s, if there were any positive T2s, and then also fungal species and the suspected source of fungemia and what treatment they got. And what we found is that we found altogether of 275 patients, and out of them, 184 were controlled, and the 91 were case, which is the COVID infection plus the fungemia. And there were altogether 8 hospitals, and 3 of the 8 hospitals accounted for more than like 50% of the study population. And there are a bunch of tables that I'm going to go through now. Basically, this is like a demographics. Total sample is column, control, which is the only COVID, and then cases would be COVID plus fungemia, and then the p-values. As you can see, there were study sites were like divided between like Robert Wood Johnson, St. Peter's, SUNY Downstate, Newark Beth Israel, University Hospital, RWJ Livingston, Montefiore, and Jersey Shore. And the top top hospitals where we get this data was from like Robert Wood Johnson, Newark, Beth Israel, and University Hospital. When you come to look at the age were about 62 in the cases, and then the controls were 67, and there were about 10 patients altogether who were over 89, and mainly most of it was in the control group. When it comes to gender, it was males were more dominant in both cases and control, more into the cases. And then the primary race was, if you look at it, the cases is 42% were about African American or Black, followed by Caucasian white, and Hispanic and Latino afterwards, about 20 to 18%. And then similar findings for the controls as well. In terms of the past medical history, we had a variety of medical history with the patient that we included. They were pretty much equal, I would say, in terms of like distributions of like the heart disease or diabetes and ESRD. When it comes to percentage, if you look at the percentage versus the numbers, because it's 2-to-1 ratio, right? And then also we had some malignancy patients as well, about 27, 17 were in the controls, and the 10 were in cases. And then we had 7 solid organ transplant. Some HIV, but not as many. And as well as like the BMI was about pretty equal, 31 versus 30.8 into the big case and controls. And then out of them, only 13 patients had chronic steroid use for their past medical history, like COPD or RA or other histories. And they were mainly in the controls. Now, more detail about the data collection in terms of like hospital admission details. So we wanted to see also like the symptoms, how many days of symptoms they had pre-admissions. So the controls in case, they both are about similar, 6 and 6. And in terms of length of stay in hospital, total stay, it was higher in case with the fungemia and COVID patient, which was 44 days versus 19 days in the controls, which makes sense. They're a lot sicker and they were in the hospital for more longer. In terms of the SOPA score, it's about 7.4, 7.2. And so that shows that like both of the groups had a similar severity. In terms of the length in ICU stay, it's about 25 days in the COVID and fungemic patient versus only the 13 days, 13.8 days in only the controls without Candidemia. Now, in terms of what they used, like the supplemental oxygen, nasal cannula, non-rebreather, we divided into them, high flow, BiPAP, or intubated. So not necessarily one patient was only on one thing, but it could be multiple mix of all of this. So I like the intubated numbers because most majority of patients end up getting intubated. And so you could see 69% was in the case and 38% was in the control. So there were a lot more double patient in the intubated in the COVID and fungemic group. There were one patient who was on VV ECMO, and that was also in the case. In terms of tracheostomy, there were more patients who had tracheostomy done in the cases in fungemic patient, which makes sense because they were intubated for a longer time. They were in ICU for a longer time. And when it comes to central line, you could see there were like 86 patients in case and the controls were 87, and which turns out to be 94% in the cases and 47% in the controls. And the duration of the central line is about 24.7, 25 days and versus 16.9, and which also makes sense. And those were all clinically significant. Most of the stuff, as you can see, is clinically significant. In terms of biomarkers and other lab values that we collected, I didn't find major differences. They're pretty much similar across the both group. CRP was about 11 in both group. Ferritin was about 725 and a little bit higher in the cases. LDH was equal. D-dimer was pretty much same. WBCs, lymphocytes, and neutrophils. So there was not much very difference in those labs. When it comes to the treatment, we looked at what kind of steroids they received and the duration of the steroids as well, and then the antibiotics. So the majority patient received dexamethasone, and that accounted for like 81 control, and the fungemic and COVID were 38. Hydrocortisone was about 18 and 18 equal, but the percentage is of course different. And then methylprednisone was second, and then the prednisone. And they were on about, the duration was about 11 days, 11.6 days for the COVID and fungemic, and the 10.2 days for the controls. And the total duration of antimicrobial use was a lot more. Patients were on antibiotics for a lot longer for COVID and fungemia versus the control group. And that was also significant, clinical significant. Now, when it comes to like biologics and other therapy, so the number one runner was tocilizumab. And there are other three that we noted, infliximab, serilimumab, and siltuximab, but I believe those were not used as a primary treatment, if I have to guess, but there were patients with RA, some other medical conditions that they were using it because of that, but not, they were actively given, or I just don't have exact detail, but I don't think they were mainly used as a treatment. But tocilizumab was the one that was used, it was 90% and 88%. In terms of the convalescent plasma, only 3 patients received it. Immunoglobulins, only 1. In terms of chemotherapy, they were all in the control groups, and only 4 patients were receiving that. In terms of the paralytics, we only cystaticurium was the main agent that was used. It was 33 patients, which is 84%, and 88% into the control. And rocuronium and bacterium was the next were minimally used. They were significant statistically. In terms of looking at the suspected source of fungemia, we found the higher number with the line related, which is expected with the if there's an epic line, central line, or any other line infection. Bowel perforation or intra-abdominal infection was about 6 cases. And then rest were just very minimal: colonization, lung, TPN or trach, or like a urinary translocation related. There were about 20 were unknown, and there were multiple reasons for about 8 cases. In terms of the fungemia, we also collected the diagnosis of fungemia from the admission, which was about 25 days. And then also the fungemia diagnosis from the positive COVID test, which was about 24. And basically that tells me that like mainly patients were admitted with COVID, and they turned out to be, they became fungemic on day 24 to 25. Hours, we also wanted to see how long it took for the antifungal therapy to start, and from the diagnosis, so which was about 16 hours, and total therapy duration for the antifungal were about 10 days. And also wanted to see how long did it took from positive fungal culture to negative, and which was about 3.7 days. And these were the candidal species that we encountered. Most of it were isolated. The number 1 is the Candida albicans, which was about 52%. Glabrata was 18. Tropicalis was 15. Parapsilosis were 11. And Cruzia and Oris next 2. And there were others that was about 7.7%, and was like basically Candida dublinensis, Yermondi, Lusitania, and Nevarensis. Very minor number. At the end of the collection, we found out that like the outcome for the patients would be recorded either in discharge or either they were deceased. So altogether, in the controls, you could see that there were 110 patients were discharged and 74 were deceased. When it comes to cases with COVID plus fungemia, you see that like the discharge were about 29 and deceased were 62. So there were a lot higher rate of mortality with the COVID plus fungemia. And so there was a logistic regression was done to find out identify the risk factors for the fungemia. And in the unmatched fungemia analysis, basically 2 to 1 instead of just match 1 to 1, we found that the central line insertion, paralytic, and a biologic were associated with developing fungemia. And also, this is the IL-6 inhibitor one we see, and then it also correlated with the development of fungemia. And in last thing, basically in conclusion, is we're still waiting on one of few other logistic regression models for the risk factors to find out for the fungemia. But so far, it seems like that longer stay in ICU, central line use of paralytics and biologics associated with increased risk of candidemia, and of candidemia and COVID has a higher mortality compared to the non-candidemia patients. These are my references. Any questions?
Okay, I'll start with questions. Did you do any sort of multivariate analysis? Because it seems to me that, you know, if the onset of candidemia was like day 28 or something like that, by that point, most of the ones who were non-candidemic were gone out of the hospital. So is this all just a function of severity of illness and length of stay? Because paralytics and central lines and all those things go with severely ill ICU patients.
Yeah, I believe this one was multivariant analysis, Dr. Borokoff, but I just I didn't include it in the last analysis that we received.
And when you talked about days from fungi, you know, positive blood cultures to negative blood cultures, was that just a function of when the blood culture turned positive? You know, in other words, how many patients, once you got the positive blood culture with Candida, had a repeat blood culture with Candida in it? Or, you know, were they all negative at the time of the repeat blood cultures?
So our patient, they were all, some were T2 and some were blood cultures. So once the blood culture turned positive after third setting, they did have a blood culture that were negative. I didn't understand the question.
My question is, when you got a positive culture or T2 or whatever, and then you repeated the cultures, how many of those were positive? Were there many that were positive on that repeat, or were they all negative?
I see your question. I don't have the exact number for you. I cannot speak for other sites, but I don't think we had a lot of them were remained positive after the initial blood cultures.
So maybe these were all, you know, so you can't say that the antifungal cleared the bloodstream.
No, that's a good way to point it out, I guess. Discuss later again, maybe take a look at it.
So Purvi, that was really good. You have a ton of data in there, and it's obviously a complex group of patients. The one thing I just want to make sure is when you're looking at risk factors, so basically, you know, you looked at risk factors and you also looked at outcomes, right? So when you're looking at risk factors for the candidemia, you only want to include things that happen prior to the candidemia in your cases, right? For your controls, it's the entire duration of hospitalization. But for candidemia, it's only that, you know, time period leading up to it. So just, you know, when you're looking at things like paralytics, when you're looking at things like, you know, anything that could be a risk, you're looking at, you know, IL-6 inhibitor treatments, et cetera, you only want to make sure that you limit that in cases up to the point that they had the candidemia, right?
Mm-hmm.
Because that's everything after that is no longer a risk factor, right? That could be attributed to actually the infection itself. And I guess one question that I know you showed some data on, you know, the impact, you know, outcomes, comparing candidemic COVID positive patients to candidemic non-COVID positive patients from another study.
Mm-hmm.
How do you think the attributable outcomes that you showed and things like length of stay and such, how do those compare to candidemia in sort of sick non-COVID positive patients? Do you think there's a similar impact, or do you think there's a proportional impact in COVID-19 positive patients, or what's your thought, or have you not, is that something that you think is difficult to compare?
I mean, it is kind of difficult to compare, but also it's kind of, you could generalize it in terms of like those studies they compared with the non-COVID patients. So like that was a different ball game versus the COVID that's different not exactly different pathophysiology, like patient was a lot sicker, they stayed in ICU for longer. I don't remember if they have a length of stay measured in the other article, but that would be interesting to take a look at it and see if there's any comparison versus how sick the patients were as well.
And the univariate table for your length of stay, it's probably good to look at length of stay in your cases prior to candidemia and your length of stay after, to break it out. Because as Susan's saying, you know, you did mention the length of stay later not initially, but sort of later on in your presentation was quite
Yeah.
long
Yeah.
in your cases. And I just, even if you compare that, length of stay prior to candidemia to the total length of stay in your controls, I wonder how those numbers would shake out, because this did seem like a really sick group. And I think
Yeah.
Susan's point is good, and
Yeah.
I forget, did you have an acute measure of severity of illness? I know you had the Charleston for chronic, but did you look at anything like SOFA or Apache? And maybe I missed it.
SOFA was there. We did look at the SOFA
Yeah,
score.
the SOFA were similar, right?
Yes, it was.
And the SOFA was
And
at the time of ICU admission?
yes, 24 hours prior. And I
Right,
think
the
it will
ICU
be,
admission, wait, were all the patients in the ICU?
they had to be in ICU, yeah.
So all
One
the
way, they might not
controls-
have been admitted in the ICU in the beginning, but later on they ended up escalating the care because they were on high flow, continuous high flow, or intubated.
And the controls were all in the ICU as well.
Yes, we try to match them as much as we can, yes.
So that duration of stay in the ICU prior to infection, not just duration of stay, but duration of stay in the ICU prior to infection, is going to be an important variable to look at.
Yes, I see what your point is, but I think it might be difficult to differentiate because we have an admission date and we have the discharge date. So you could find out when the fungemia was positive and the rest of the days for how long their stay was. But it might be difficult. We have to go back into every single patient to find out when they were discharged from ICU to floors or from home or passed away. So I think that might be a discussion that we have to do with them.
Purvi, if he's talking about before the admission, not after, not before the fungemia. And if I can show you how to do that very quickly on cases in SCM. I don't know how they do it in other sites necessarily.
Okay.
But, do you have your slides? Can you show us again where your length of stay slide?
Yep. All right, just give me a second. Can you see it?
Yep. So the length of stay for your control patients was 19.8 days.
Yes.
And now go to the one where you're talking about the fungemia and the time to fungemia.
I think it was 24 days, Susan. That would be something that they could work into the model.
Yeah,
Yep.
that's part of what I'm trying to say is by the time these people were fungemic, the mean, the average patient was already
Out.
So is this just a marker for these are sicker patients?
Yeah.
Yeah,
And yeah.
COVID have anything specific to do with it? I'm not sure that this is, based on what you're looking at, all you could say is outcomes of patients with fungemia in, COVID patients compared with as matched as possible patients with COVID who didn't have fungemia. But if fungemia is really just a marker for these were the sickest of the sick COVID patients, then, the applicability of these results is a little bit more limited.
I see.
One thing you could work into your model to help address that would be the duration of hospitalization prior to fungemia. In your controls, it's going to be their entire duration, which would be the 19 days. And in your cases, it would be that 24 days or 25 days. If you work that into model, that might help additionally adjust for severity of a marker for severity of illness.
Okay. Yeah, I'll
Just
bring
a
it up.
suggestion. There's incredibly complex data to work with. And I appreciate that. And you've done a really nice job in terms of evaluating it and making it sort of interpretable. Because it's it's messy data to work with. So I appreciate how complicated it is. You've done a nice job and a nice presentation.
It seems like looking at it really quickly, it doesn't look like that this were included in terms of the days. You pointed out, I guess I'll point it out to Dipali. I don't know if she's still there or not, but I think that would be interesting to see. But thank you for all the good comments.
Any other comments or questions for Purvi?
Thank you, Purvi. I think you did a great job.
Purvi.
Thank you.
Great job. Okay, everyone, I think our faculty and Nav, we wanted to stay on for a bit.